welcome to GU Oncology Now. My name is Crain Garrot. I'm a medical oncologist with Georgia Cancer Specialist, part of Northside Hospital Cancer Institute. And I'm joined with multiple colleagues that I work with in the community to talk about prostate cancer. And I was going to let all my colleagues introduce themselves.
Thanks, Dr. Garrot. My name is Dr. Yasin Bhanji. I'm a urologist with Georgia Urology here in Atlanta, and excited to talk about some of the latest innovations in the advanced prostate cancer space today.
Hi, I'm Dr. Shailesh Satpute. I'm one of the medical oncologists. I'm a colleague of Dr. Garrot's. I am from Georgia Cancer Specialist, and I practice out of Sandy Springs area of Atlanta.
Hi, I'm Dr. Caroline Liu. I am a urologist with Georgia Urology. Happy to be here to chime into the conversation.
My name is Froylan Gonzalez. I'm also a urologist that work with these fine physicians in the community. I have a special interest in prostate cancer as well, both from a professional and personal standpoint, and I'm glad to be here.
Okay, well, let's get started. We kind of wanted to go over the sort of the landscape and the diagnostic parts of metastatic prostate cancer. And Dr. Liu, I was going to ask you if you could sort of go through how you look at hormone-sensitive or castrate-sensitive versus castrate-resistant prostate cancer. What are some of the characteristics in laboratory, and even how do you talk to your patients about those two things?
Yeah, absolutely. So first of all, I think it's really important to try to distinguish what category you're in, hormone-sensitive, hormone-resistant. There's a lot of things that we do in the urology office. In terms of lab tests, I do serial PSAs to follow these patients every 3 to 6 months or so, kind of get a sense of their PSA doubling time, which is really important. I try to make sure that their testosterone levels are below 50 to indicate they're supposed to be in castration status there. There's some imaging studies that we can do as well. There's conventional imaging like CT or MRIs, bone scans, and we've also seen the rise of some of the newer imaging like PSMA PET scans, and trying to figure out what's going on with the prostate cancer.
Gotcha. So one of the things that you mentioned was PSMA PET scans. And Dr. Bhanji, I was going to wonder, how are you integrating that into the initial diagnosis and then follow-up of patients?
Yeah. I think next generation imaging has really transformed how we manage both localized and kind of advanced prostate cancer. From a localized prostate cancer perspective, and in patients who present with higher risk disease or even unfavorable intermediate risk disease, next generation imaging helps us, perform that initial staging exam. Even when we are looking for localized prostate cancer, we have instances where we will find or suspect MRI invisible disease, which is actually identified by next generation imaging like PSMA PET scans, which can actually help us perform targeted biopsies and identify disease which may have otherwise been missed by more conventional modalities like MRI. Even beyond that localized prostate cancer stage, when we think about higher risk patients, we're looking for, the possibility of locally advanced disease or even micrometastatic disease, which, based on imaging modalities like MRI are not very obvious. This can inform our surgical approach, but also, tell us if maybe surgery is not the best option for that patient in terms of achieving the best long-term outcome.
One of the things that happens is a man will get on ADT and an ARPI, and he has a good outcome. He has a PSA that drops, and we obviously take that as evidence that it's a patient's in remission. But one of the things I think that's hard for us to kind of define and do regularly is when do you scan? I'll give the example. So in medical oncology, when we have a lung cancer patient or a gastric cancer patient, we scan every 3 or 4 months because that's really the best way we can follow that patient. But with prostate cancer, we have the PSA. So Dr. Gonzalez, I was going to ask you, do you have sort of like a schedule of imaging with either conventional imaging or PSMA PET scanning that you do even though the PSA is in a satisfactory level?
Yeah, I think that's a great, interesting question. In years past, my management of prostate cancer was very PSA heavy and dependent. Conventional imaging, CT scan, even PET scan in the past wasn't helpful in the management of these patients, even in advanced disease. By the time we saw distant disease in a conventional imaging, that patient was pretty far progressed. With the advent and the use of these more advanced imaging techniques, particularly the PSMA PET scanning, we've realized that we can see this disease much earlier in the process. So in years past, if the PSA was undetectable, I would not get testing.
Yeah.
But we've realized over time that sometimes we can actually see disease progression and also worsening of metastatic disease even with the undetectable PSA. And the concerning part is that these cancers tend to be much more aggressive.
Yeah.
They're more anaplastic. They're so anaplastic, they're not even making PSA. They're so different than normal prostate cancer, they tend to be even more aggressive. And it kind of is a corollary to the digital rectal exam. A lot of people say, oh, if the PSA is not elevated, don't worry about a digital rectal exam. But it's still an important test because it helps us find certain prostate cancers that are not PSA dependent or showing a PSA rise. In the same setting, I tend to get a PSMA PET scan about once a year.
Yeah.
If the PSA is undetectable, the patient's doing well. If they have new symptomatology of bone pain or other issues, I may get a scan for cause.
Yeah.
I have pretty much gotten away from conventional imaging. I find that the PSMA testing and PET scanning has gotten so much better at finding distant disease. I find it just more radiation to the patient that is unnecessary.
Yeah. Does that sound like an interval of time?
Yeah, I'd like to echo what Dr. Gonzalez said. I think what's interesting and something that we kind of have to wrestle with is that if you look at many of the major trials that have been done for metastatic hormone-sensitive prostate cancer, many of these trials were all based on findings on conventional imaging, not next-generation imaging. Obviously, like Dr. Gonzalez said, we are now becoming more reliant on this next generation imaging. But how do we kind of mitigate the data that we rely on in the trials, which have all used conventional imaging, with now very sensitive, very specific, PET scanning, which is sometimes we're finding things which, can cause the patient anxiety, can cause us anxiety, and we feel that now we have to do something. So I think it's an interesting paradox that we're dealing with as we do more PSMA PET scanning.
I guess I'll agree with maybe a year-ish type of time frame. That's what I also think is reasonable. I have had patients that had gone years on just PSA assessment alone, and then you're kind of like, well, where's the disease? You don't know where it is, so it's good to keep watching.
Biggest challenge is convincing the payers to pay for a scan with a negative PSA, or undetectable PSA. That's been my biggest challenge.
I think you're right.